You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 31st, 2025. This week, another negative AF ablation trial, predicting atrial fib after stroke, the value of randomized controlled trials, troponin testing in the emergency department, and the choice of aortic valve replacement type. Let's start with another negative AF ablation trial. The Adelaide, Australia team has once again added to the knowledge base of AF treatment with a clean, well-conducted RCT looking at another AF ablation strategy. First, some background. About 10 years ago, Canadian investigators published the STAR AF2 trial comparing 3 ablation strategies in patients with persistent AF. This was PVI alone, PVI plus lines, and PVI plus ablation of complex fractionated atrial electrograms. These results have stood the test of time. The trial found no difference in AF recurrences, and PVI alone was established as a less is more strategy. This was, and sort of is, a disruptive finding because people believed, and some still do, that because patients with persistent AFib often have atrial structural disease like fibrosis or atrial dilatation, that PVI alone would not be enough. But to date, only 2 studies of many have found that extra ablation beyond PVI adds to anything. This was an alcohol vein of Marshall ablation study and a hybrid surgical and catheter ablation study and a modestly reduced AFib, but both of these studies had small effect sizes and were statistically fragile. The vast majority of studies have shown that PVI alone is sufficient. The Adelaide group had the idea of studying CS isolation added to PVI. So they performed a simple RCT. It turns out that you can isolate the CS by doing endocardial and epicardial within the CS ablation. And you just eliminate electrograms in the CS. And the thought is that by eliminating these electrograms, you'll eliminate a driver of AFib. So the trial was a fairly simple trial. 50 patients had PVI plus CS isolation, and the other group had no CS isolation. Now, it turns out that both groups in Adelaide had a roofline ablation where they connected the PVI lesions. At 2 years, there was no difference in arrhythmia-free survival. The Kaplan-Meier curves were identical. While there were no statistical differences in adverse effects, there was 1 stroke and 1 pericardial effusion that occurred in the CS isolation group versus 0 for both in the CSI group. Now, my comments. There is not much to add here other than to say, A, congratulations to the team for doing a proper RCT, and B, it's pretty clear that CS isolation does not help, so don't do it. Now, some might ask whether there were enough patients and could this be a false negative finding? And I'd argue against this thesis. Not only was the p-value in this study 0.9, so almost 1, but also from a Bayesian view, you have STAR AF2, which provides a very pessimistic prior. So the combination of a negative prior plus a negative set of data should lead to a very negative posterior. Finally, my friends, this is the way to answer questions in medicine. Don't look back with retrospective data. Prospectively randomize patients and then study outcomes. Now, I'll get to later, it's sometimes not possible to do this, but a lot of times it is, and in this case it is, and congratulations to the Adelaide team. All right, next topic is predicting AF after ischemic stroke. Now, I don't know about your hospital, but a lot of post-stroke expensive loop recorders get placed in our place. The purpose, of course, is to detect AFib, then use oral anticoagulation, and then reduce recurrent stroke. It's a good purpose. People are well-intentioned in putting these loop recorders in. Yet, the financial incentives for these things are huge. I'm not sure how it happened this way, but the hospital makes a lot of money from these loop recorders. the doctor makes money, and there's this recurring revenue stream. Every month, the device is downloaded. I know this because many patients that I have complained to me that they get monthly bills and they have copays. They've even asked if they can be taken off monitoring. And there were studies, like the famous Crystal AF study, which showed that longer-term monitoring detects more AFib than short-term monitoring. But yet we don't have outcome data. Does the expense of an ILR result in fewer strokes? This is an especially relevant question now that we have had incredibly persuasive data from the LOOP trial, from NOAA, from Artesia, and all these studies show that short duration asymptomatic AFib, the kind that you pick up on an ILR, confers a very low yearly stroke rate. What's more, many patients who receive a post-stroke ILR never have AF detected. It gets put in, but there's no AF. Well, perhaps there is an interim step between doing a randomized controlled trial. Perhaps there are predictors from clinical features or the ECG or a combination of both that might enrich a population with patients who will have AF detected on this loop recorder. So if you could predict that, post-stroke ILR use could be more cost-effective. And the journal Heart Rhythm has published a meta-analysis of 75 studies with 58 prediction models to try and predict patients who would have AFib after a stroke. The first author is Anna Helbitz and colleagues from the UK, Canada, and Denmark. Now, here I have another short report. Most of the studies included were at a high risk of bias. A handful had good discrimination, a C statistic around 0.85, but no model in this meta-analysis had excellent discrimination when limited to external validations or studies that had more than 100 AF events, and no studies considered clinical outcomes. In other words, none of these combinations of clinical or ECG criteria were usable in clinical practice. Now, my comments, the first thing to say is to remember the old saying that prediction is hard, especially about the future. Post-stroke monitoring, I think, is a well-intentioned endeavor, but empirical data is weak. This meta-analysis suggests that many people have tried to find this constellation of symptoms or signs that will predict AFib, but none are reliable enough to use clinically. Now, other people have tested the idea that we should just use oral anticoagulation in patients with embolic stroke of unknown origin. This makes perfect sense, right? Because when you see an embolic stroke and there is no other obvious atherosclerotic source, it must be due to a clot somewhere else, and oral anticoagulation should work. Except it doesn't. 3 RCTs, Respect ESIS with dabigatran, Navigate ESIS with rivaroxaban, and last year we had Arcadia with apixaban, and Arcadia was enriched with patients who had atrial disease. But all of these failed to reduce stroke with empiric oral anticoagulation. Therefore, to me, this is a perfect scenario for a strategy trial. You randomize stroke patients who don't have an atherosclerotic source to an ILR monitoring or ECG patch recording or even home ECG monitoring with a cardio-like device, and then you measure outcomes. It will take a big sample size, but such a trial is doable and it should be done. Now, this is a perfect segue to the next topic, which is RCTs, and I found a great review paper. The paper is titled Large, Simple, Randomized Controlled Trials from Drugs to Medical Devices, Lessons from Recent Experience. The first author is Sergio Buccieri, and it's published open access in the BMC journal called Trials. It's a review paper, but it's well written and it's topical and important. The authors describe recent successes in doing large, simple RCTs using modern IT infrastructure. One was the recovery trial that was done in the UK during the COVID-19 pandemic. The other is one of my favorite trials of all time, and this is the TASTE trial of thrombus aspiration during STEMI. Now, TASTE was done as part of the SWEDEHEART program, which stands for Swedish Web System for Enhancement and Development of Evidence-Based Care in Heart Disease, evaluated according to recommended therapies, SWEDEHEART. It was launched in 2009. It collects data consecutively on all patients with these different cardiac conditions who require specialist medical management or interventional or surgical expertise. Patients are informed about their proposed inclusion in Sweetheart when they present to a cardiology service. And then they are registered using the personal identification number, which is nice. Sweden and Northern European countries have this. Now, Sweetheart was used to conduct a taste trial, which compared manual aspiration of intracoronary thrombus before PCI versus standard PCI without thrombus aspiration in patients with acute MI who had primary PCI. Now, the design of the taste trial was kept very simple by employing a minimal set of exclusion criteria and by obtaining the primary endpoint of all-cause mortality by directly linking to the Swedish population registry. There was also minimal administrative burden that was imposed on the investigators because they used clinical and follow-up information that was already collected. They avoided separate monitoring, separate adjudication of adverse events. Then, all hospitals performing PCI in Sweden contributed to the screening and randomization of 7,200 patients within less than 3 years' time. Now, what kills me every time I watch a PCI during a STEMI is that TASTE trial found absolutely no difference in death or a composite of death, rehospitalization for MI, or stent thrombosis at 30 days or 1 year. How is this possible? I mean, the clot is huge. How does it not get squished and just go downstream and cause all kinds of problems? But it doesn't. But anyways, the author's point in this review paper is not to emphasize the shocking findings of the trial or how almost no interventional cardiologist anywhere has stopped routinely aspirating thrombus, but that the TASTE trial was made simple by creating a system friendly to RCTs. Now, when I go around to lecture, I'm often asked what the next big development in cardiology or medicine is going to be. And I really can't think of a new device or new medicine that could possibly break our curse that we have of incremental gains over the last few years. But one thing I do think could seriously improve healthcare would be a much stronger culture of randomization. I don't know about you, but we don't randomize many patients because there isn't infrastructure. There's just not an available trial for us to put patients in. Now, we're doing the left versus left trial of CRT versus conduction system pacing in CRT-eligible patients. But this is just one specific question. And the left versus left trialist got a multi-million-dollar grant from PCORI, from the government. Now, this trial has oodles of paperwork. It requires multiple research coordinators. It's a gargantuan project in size. But wouldn't a better solution be to have a Sweetheart-like format where you could more easily streamline patients in the trials? Now, the most striking aspect of visiting hospitals in Denmark is that when you walk around, there's large numbers of patients in the trials. You walk down the hallway. From the hallway, these look like regular patients getting regular medical care. But this patient's in a trial, that patient's in a different trial. Being in a trial massively increases our knowledge base going forward. Just the fact that thrombus aspiration does not work, or that oral anticoagulants in embolic stroke of unknown origin doesn't work, should motivate every single doctor everywhere to want to randomize more of their patients. The review paper also warned us about something I see too often. If you're going to do RCTs, they have to be proper RCTs. They need to be large enough to answer questions. Underpowered trials are an ethical disaster, right? Because this means you've experimented on humans and you could not answer the question. Another issue discussed in the paper is that clinical trials should focus on important outcomes. For instance, reduction of BNP or other biomarkers. These surrogate markers is a waste of money, also borderline unethical in my opinion. Surrogate outcomes should be used extremely sparing. You need to measure important clinical outcomes. I'd encourage everybody to read this review paper. I think you will learn enough, and I'm going to stop ranting about RCTs. The next topic is troponin testing in the emergency department. JAMA Internal Medicine has published a research letter from a group at Harvard looking at cardiac biomarker use in the ED. The first author is Cian McCarthy. This was mostly troponin measurements. Few topics in clinical cardiology could be more relevant than dealing with biomarkers. While it should not be, because a biomarker is just a test, much folly follows from misuse of these biomarker tests. The research letter used a sample from the National Hospital Ambulatory Medical Care Survey. It examined about 100,000 emergency department visits, which was just a weighted sample of millions of visits between 2014 and 2022. So the findings were that the overall enzymes were measured in 7% of all ED visits, and this really didn't change much over a decade. Nearly 1 in 3 patients come to ED get an ECG. Now, among those patients who have enzyme testing, about a third had chest pain, a little more than a third had non-chest pain anginal equivalent symptoms, and about 1 in 4 had no anginal symptoms. Now, not surprising was that abnormal vital signs increased the odds of having biomarkers done. Interestingly, and I can't explain it, Asian versus white race doubled the odds of having an enzyme test, as did the presence of cerebrovascular disease. Now, only 3% of patients with an enzyme test had an ACS diagnosis. Also not surprising was that ACS was more commonly diagnosed in those with chest pain than those with non-chest pain anginal equivalents or non-anginal symptoms. The authors concluded that A, 2/3 of patients who had enzymes measured did not have cardiac symptoms suggestive of angina, and B, of those, less than 2% had ACS, which they write, quote, is a threshold below which the harms of evaluating for MI may outweigh the benefits. Another finding that surprised the authors and me was that 75% of patients with chest pain did not even have cardiac biomarker testing. I have trouble explaining that, although I just wonder if this is related to the diagnostic codes or whatever. Someone has chest pain from pneumonia or from trauma and doesn't get an enzyme test. Now, my comments. I could ramble on about the folly of biomarker testing for many minutes, but I'll try and keep it brief. My brain plays 2 movies in regard to troponin testing. One movie says docs should stop ordering these tests when the diagnosis is not due to plaque rupture, ACS. The classic scenario is the patient with AFib or SVT. This patient played pickleball in the heat of the summer and felt fine, no problems, no angina. Later that night or sometime later, they go into AFib with a rapid rate. Hours later, they come to the ED. Their heart's been racing. And of course, they have uneasiness in their chest. Who doesn't? The problem is not an MI due to plaque rupture here. The problem is AFib and tachycardia. But someone draws a troponin, and it comes back elevated. And then this breaks the brains of everybody taking care of the patient. Now the patient is sitting there with this big red arrow in their chart with a high troponin. They get put on to rule out or rule in or whatever pathway this is called. And instead of getting aggressive rate control of the AFib or maybe an EP consult, everyone worries about ischemia because of that big red troponin in the chart. The next day, the patient gets angiography, and they're still tachycardic, by the way. Then, a mid-circumflex lesion is stented, despite it being totally incidental. Then EP gets consulted to care for the AF, and the patient is now taking 2 antiplatelets and now has to take a 3rd antithrombotic medicine in the form of anticoagulation. This happens all the time. It gives me a rash. It's just crazy. So, the first movie says, don't measure the biomarker, then you won't start this cascade. But here's another movie playing in my head. This one says it shouldn't matter what the enzyme test is. The test is not the problem, it's the misuse of the test. Now I'm going to do self-citation like all academics do. In 2021, Andrew Foy and I attempted to cure the world of a troponin misuse in a 1,000-word editorial in JAMA Internal Medicine, which I'll link to. We made this beautiful table. The paper is called Updating Our Thinking on Troponin Use and Interpretation, and sadly, it's only been viewed 6,000 times, which is less than a blog post. Our take in the editorial is this. If the patient with an elevated troponin is having a clinical scenario consistent with a type 1 MI due to a plaque rupture, in other words, an ACS, then treat the patient with antiplatelet drugs and revascularization like you would with any STEMI or non-STEMI. But every other cause of elevated troponin, whether it is type 2 MI from tachycardia, shock, or anemia, or acute myocardial injury from heart failure or an ICD shock or myocarditis, or chronic myocardial ischemia from, say, CKD or chemotherapy or critical illness, then the treatment is the same, to treat the underlying cause. So nobody needs to be confused. The movie says you could do troponin on everyone coming to the ED, and no one should be mistreated. If the troponin is elevated and there's not an ACS, there's not chest pain or ECG changes, then you just treat the underlying cause. Correct the rate of the AFib, correct the anemia, or correct the hypoxemia. So, my friends, help me spread this message. A, don't measure troponins when you don't suspect ACS. Or B, if you do measure the troponin and there is not an ACS, then just treat the underlying cause. All right, final topic today is on the choice of aortic valve. I personally am glad I don't have AS, and I've not had to choose between a mechanical or bioprosthetic AVR. It's not a hard choice for older patients who should just have the bioprosthetic valve, but for middle-aged people, it is a really tough call. Just to make it really simple, a mechanical valve, I call them clickers, they go on forever. But you have to take warfarin, which is usually fine, but sometimes it isn't fine. Yet choosing a bioprosthetic valve at age 50 means that if you don't die of a bike wreck or cancer or 1,000 other things, you might need multiple aortic valve surgeries. And if you've had one time open in your chest, you're not likely going to like the second or third. So if I had to make this choice, being an evidence-based doctor, I might ask about outcomes. Now, while the valve choice has clear potential pros and cons, can we say which one leads to better survival? That might be an important data point. To answer this, you would want to have a massive RCT. The RCT would have to follow patients for a decade or more. So you can probably guess that such an RCT does not exist. In fact, I can't think of many RCTs that follow patients for more than 5 years. It's barely feasible to do so, right? Because there's cost and patients move. It's really hard to do long RCTs. This week in JACC, multiple authors attempt to assess survival using observational data. They use the STS database. And the STS database is great, but it's still retrospective observational. They had about 110,000 patients who had AVR during an 11-year period, 2008 to 2019. 94,000 patients had bioprosthetic and 8,000 had mechanical AVR. So there you have two comparison groups. The authors report three main findings. One is that the mechanical AVR use has declined from 20% to 10% over the period. Second, for patients younger than 60, mechanical AVR was associated with a lower risk of death. Third, after extensive sensitivity analysis, it's still confirmed that mechanical AVR was associated with reduced all-cause mortality. This includes things like aortic insufficiency and intermediate high surgical risk. So in the paper, the main Kaplan-Meier curves are similar, but then diverge in favor of mechanical AVR after about 5 years. Then the paper has these graphs with age of valve surgery on the x-axis and adjusted survival on the y-axis, and the hazard ratio favors mechanical AVRs until the age of about 60 or 65, but the confidence intervals are wide around that time. In my comments, this is a good intentioned effort, I know. I mean no malice to the authors, but it's a terrible idea. This is a classic situation where there are oodles of factors that go into the choice of the valve. Some of these factors come out on a spreadsheet, things like creatinine or diabetes or blood pressure, but many of these things don't come on a spreadsheet. And it seems blatantly obvious to me that only the healthiest or best patients receive a mechanical AVR, and surely it is these factors that improve survival. There's just no way to be sure that the observational study is not biased. So I ask, why even do such an analysis? Now, I know what some people say. Some argue that in the absence of RCTs, such an analysis is better than nothing, but I disagree with that. It's better just to say, I don't know about survival because it's impossible to know such different patients get different valves. This is one situation where I think we just have to accept the uncertainty, go with the pros and cons, and I'm not sure it's ever going to be an answerable question in an RCT because patients are so different and you require such a long time of follow-up. Okay, so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating. If you don't agree with anything I said, send me a note, write a comment on the heart.org webpage. I learn from these comments. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.